Hi, my name is Tariq Adar, and today we'll be talking about tumor suppressor genes. So a little bit of information about my background. I know I say a lot of stuff like this is high yield, you're going to know, you need to know it, it'll show up on an exam. So I am a third year medical student. I have taken step one, I'm preparing for step two, and I'm currently in my clinical rotation. So when I say that something is high yield and it'll definitely show up, usually what I mean is that I've either seen it in clinical practice, or I've seen it on an exam, or I've seen it on both, whether they're shelf exams or, um, other exams. Don't want to get myself in trouble here, but they are very important concepts, and the reason why they show up on exams is because they're testing, fundamental physiologic and pathologic features. So that's sort of what I mean when I say that something is high yield and that you need to know it. All right, just wanted to clear that up. So the first of the tumor suppressor genes that we're going to talk about is TP53. All right, so P53 is the protein encoded by the TP53 gene. All right, and this is a pretty high yield one because P53 is the guardian of the genome. So it maintains or it monitors the integrity. And sort of what happens in the presence of abnormalities in the cell cycle, if there's damage to the DNA, or in cases of low oxygen, what P53 does, it's going to stop cell division and it'll try to fix the issue. If the issue can be fixed, the cell cycle will start over. If the issue can't be fixed and the levels of P53 continue to elevate, then programmed cell death occurs. All right? So when cellular damage occurs, P53 arrests the cell cycle until the damage is repaired. If the damage can't be repaired, you get apoptosis. All right? So what happens if P53 is mutated? So basically, none of this happens because this doesn't work. So no matter what happens, whether there's abnormalities in growth, whether there's damage to the DNA, cells can still can grow and become cancerous because P53 is no longer monitoring what's going on. P53 is the guardian of the genome. That's what it's called. And there's a cancer condition called Lee-Fraumeni syndrome, and I've seen this once or twice myself. All right, it's called Lee-Fraumeni syndrome. All right. And in Lee-Fraumeni syndrome, you're predisposed to, it's a mutation in TP53, all right, so it's autosomal dominant, and we'll talk a bit more about the inheritance pattern in a second, but it's an autosomal dominant mutation in P53, in the TP53 gene, causing a mutated P53 product that cannot prevent cancer anymore. It cannot prevent the development of cancerous cells. So patients with Lee-Fraumeni syndrome, um, they tend to develop multiple cancers. Women in particular are guaranteed breast cancer at some point in Lee-Fraumeni. The old saying is breast, bone, blood, brain. In reality, if you don't have P53, you don't have P53. So you're susceptible to cancer everywhere. You can get all kinds of tumors. But the most common ones or textbook ones are going to be brain, breast, blood, bone, and adrenals. All right. So to go and now to sort of talk about the inheritance pattern. So TP53 is autosomal dominant. In fact, all of these tumor suppressor genes, their inheritance pattern is autosomal dominant because there's a two-hit hypothesis. So remember, each gene has two copies, two different alleles. The two-hit hypothesis says you must lose one allele and then another one, right, to develop cancer. All right, you must lose one copy of the tumor suppressor and then another to develop cancer. It requires two hits. All right, as long as you have one, usually as long as you have one functional copy, you can prevent the development of cancer. However, if you've already, the reason why this is autosomal dominant in inheritance, even though you need to lose both proteins to get cancer with a tumor suppressor, the reason why it's autosomal dominant is because once you've already lost one, the odds of losing another in any one of the cells in your body at any point in your lifetime is pretty high. So it's effectively autosomal dominant. All right, so the tumor suppressor genes are autosomal dominant. Why? Because there's a two-hit hypothesis. If you're born already having one hit, it's easier to lose the other one. All right. And the second tumor suppressor I want to talk about is retinoblastoma. So elongation factor 2F is one of the factors that's required to get through that G1S checkpoint. All right. But it is sequestered or sort of held captive by retinoblastoma. All right. So when this protein called retinoblastoma, and from the name you can kind of guess what happens if it gets mutated, but if the retinoblastoma protein gets hyperphosphorylated, this elongation factor is free to go to the nucleus, and you get progression to the through the G1S checkpoint. Now, to take a step back a bit, remember that in the cell cycle normally, and we'll talk about this more on the next slide, that cyclins and cyclin-dependent kinases work together to hyperphosphorylate retinoblastoma. All right, so this cyclin and the kinase that is dependent on it, or a cyclin-dependent kinase, will phosphorylate retinoblastoma. That will cause this hyperphosphorylated retinoblastoma protein to come off of E2F, and then that will cause progression to the cell cycle. Now, let's say you have a mutation such that you're always in this state. That means that E2F is always going to be able to move the cell cycle forward. And there's two cancers in particular classically that you need to know with this retinoblastoma mutation. It's a retinoblastoma and sarcoma, all right, or bone cancer. So those are the two cancers that are, classically associated with retinoblastoma. But again, it's not, patients don't read the textbook. All right, if you have a mutation in the cell cycle protein, this is like the cell cycle switch. If p53 is the guardian of the genome and protects its integrity, retinoblastoma is sort of the gatekeeper of the cell cycle. So if you have a mutation in the gatekeeper of the cell cycle is no longer gate kept, right? So that's sort of the issue with these kinds of mutations. And as you can see here, we're sort of adding one more layer to this. One part of this image, I would kind of swap this. Here it shows retinoblastoma being phosphorylated, and that leads to transcription of genes. The reason that happens is because this E2F is free to go to transcribe the genes. This isn't particularly important, at least not at our level. All right, what I want you to be more aware of is that once retinoblastoma is hyperphosphorylated, E2F is free to initiate transcription of genes that are required for the G1S checkpoint. Now, speaking of that checkpoint, you might see here this P16 protein. But what's P16? Remember how we talked about these cyclins and these cyclin-dependent kinases and how they phosphorylate retinoblastoma so that retinoblastoma can come off of E2F and E2F can move into the nucleus and move the cell cycle forward? Well, P16 is the inhibitor of those kinases. It can also be referred to as cyclin-dependent kinase inhibitor 2A. There's a couple of other names it has, like there's P16 Inc., etc., etc. But I don't want you to memorize the name per se. What I want to illustrate here is that even the, I don't know why I erased that. Even the cyclin, so you have multiple levels of regulation. Even the cyclin-dependent kinases are regulated at some level. So it's like the genes for transcript for growth, this G1S checkpoint is regulated. The G1S checkpoint is regulated by the transcription of these genes. The transcription of these genes is regulated by the presence of E2F. The ability of E2F to be available is regulated by retinoblastoma. The ability of retinoblastoma to bind to E2F is regulated by cyclins and cyclin-dependent kinases. The ability of cyclins and cyclin-dependent kinases to remove RB so that E2F can go and be involved in transcription, that process itself is regulated by P16. All right, this inhibitor of the cyclin-dependent kinase. It just goes to show how many molecular switches there are when it comes to tumor suppression. All right. That's the main motif. I'm trying to illustrate the motif here rather than making you memorize any specific examples, besides Li-Fraumeni syndrome, retinoblastoma, the ones I'm going to explicitly name. All right. So P16, the tumor I want you to know for that is melanoma. All right, familial melanoma. All right, P16 and melanoma. And I kind of talked in another video about the APC gene. So normally, to summarize it, because I already have a different video on it, so I would refer to my Wnt signaling pathway video because I talk about this in detail. But in the presence of APC normally, will bind beta-catenin, and this binding prevents beta-catenin from acting as a transcription factor. All right, so APC binds beta-catenin, and beta-catenin can't act as a transcription factor. Okay, and if it can't act as a transcription factor, you don't get cell division, cell growth, etc., all those processes. All right, what happens is in the presence of Wnt, which is a signaling molecule, the APC protein and the complex that it makes no longer binds the beta-catenin, and that allows growth, etc., all the transcription of the genes that beta-catenin is responsible for. Unfortunately, you can get mutations in APC so that even if there isn't Wnt signaling, because normally after Wnt is supposed to be turned on during development. In a lot of the pathways that are cancerous as adults are necessary to be, and they should be switched off in adults. They're very necessary to stay turned on during embryologic development. And APC is one of those genes where normally Wnt is going to signal for it to come off, and that allows growth, etc., because Wnt is an important embryologic signal molecule. It's very important for growth and development. So it makes APC come off so that beta-catenin can go and be involved in growth development. In the adults, or in a mutation of APC, you might not want that, right? If it's not for the purpose of repairing, like a GI lining, like in the colon, if it's not physiologically switched on, and it's on because of a mutation, that's what we call bad. Because let's say APC is mutated, right? Let's say APC is mutated. That means that beta-catenin is no longer inhibited, right? If it's no longer inhibited, it's always free to act as a transcription factor. Okay, it's always free to act as a transcription factor if it's no longer inhibited. Why is it no longer inhibited? Because APC is mutated. All right, and so APC stands for adenomatous polyposis coli, which means colon gland-like tumors. That's an adenoma. It's a gland-like tumor. So colon gland-like tumor polyposis, which means the process of forming polyps. So put it all together. APC literally means that this is the gene responsible, when it's mutated, this is the gene responsible for the development of multiple gland-like tumors, many in the colon. All right, polyposis, polyp and osis meaning process. All right, and what's the condition called? Familial adenomatous polyposis. I have seen this condition in clinical practice. All right, so that brings us to BRCA1. I'm not going to go into too many details on its function. I just want you to recognize that it's associated with breast and ovarian cancer, and sort of you're going to see the motif here. It's involved in transcription regulation, DNA repair, cell cycle regulation, chromatin structure regulation. So broadly speaking, anything that opens up chromatin makes it more euchromatin instead of heterochromatin, which is repressed. The true chromatin, the euchromatin, whenever that structure opens up, you have increased transcription. All right, and BRCA is involved in some of those pathways, and it's also involved in the ubiquitination cycle, which is what breaks down proteins. When a protein is ubiquitinated or ubiquitolated, that targets it for breakdown. So through all these mechanisms, BRCA1 prevents cancer. All right, or BRCA. And the cancers you need to be most associated with are breast and ovarian cancer. All right, and there's BRCA2 for breast. But don't stress too much about that right now. All right, and just sort of a rapid fire cover of the other, kind of important tumor suppressor related things, in my humble opinion. Von Hippel-Lindau, VHL, von Hippel-Lindau. And basically, von Hippel-Lindau, that protein is a negative modulator of hypoxia-inducible factor expression. So what's hypoxia-inducible factor? Well, when you don't have a lot of oxygen, or you are hypoxic, there is a protein that can be induced, and it causes transcription of genes. In fact, this factor that can be induced by hypoxia is called a hypoxia-inducible factor, and that's HIF. And it's upregulated in tumors because if you think about tumors and what they do, they grow, they grow, they grow. They have very large energy demands. They need lots of oxygen. Sometimes they outgrow their blood supply, or they're not well vascularized. In other words, they don't have a lot of blood vessels feeding them well. So they become very anaerobic in their metabolism, and they become very adapted to hypoxic conditions. And what the von Hippel-Lindau gene does is that it negatively modulates hypoxia-inducible factor so that it's not as expressed. All right. So that's one of its functions. And in the mutation of von Hippel-Lindau syndrome, you get cancers of the kidney, cancers of blood vessels, so you form hemangioblastomas, or growths of the blood vessel lining, and you get pheochromocytomas. I don't want you to really memorize that per se. I just want you to understand mainly the kidney and hemangioblastoma correlation, and that it's a tumor suppressor gene, right? So von Hippel-Lindau, that gene is a tumor suppressor gene associated with kidney tumors, hemangioblastomas, and pheochromocytomas as well. All right. Now, we talked about P53 and we talked about the retinoblastoma protein. And this sort of brings us whole to the concept of the pap smear and why it's important. Because HPV, which is what we test for with the pap smear, right? We insert, we scrape, and we look for the degree of dysplasia. We want to see to what degree do we see carcinoma when we scrape and we do a pap smear, and then we might do a cytology. Well, we're not necessarily doing the CIN staging on the pap smear. What we do, we're going to do a pap smear. We're going to assess for HPV. If it's positive, we're going to go in, we're going to take a sample, and we're going to look for the presence of carcinoma in the basement membrane to see whether it's carcinoma in situ or not, and whether there needs to be resection of the cervix. But HPV, the reason why it can cause carcinoma or cancer in the cervix is because of two reasons. You have the E6 oncoprotein and the E7 oncoprotein. All right. So oncoproteins are unlike tumor suppressors, and we're going to have a whole different lecture on some of the common ones there. But oncoproteins, instead of tumor suppressors, are pro-growth. They are growth proteins, onco-tumor. They are tumor proteins, growth proteins. They drive growth in the cell cycle, which is necessary if you're a tumor. So for HPV, it's E6 oncoprotein because of the effect that it has on the human cell. E6 will tag P53 for ubiquitination. You remember what we said about ubiquitination? When a protein is ubiquitinated, it is destroyed. All right. And can a destroyed P53 be the guardian of the genome? No, it cannot. So what happens in cervix cells, right? Because if you think of HPV being secreted in bodily fluids, where's the semen going to go? Most likely, the vagina and the cervix, and that's going to cause infection of what? The cervix, because HPV has a predilection for the squamous cells. And what's going to happen then? You're going to get E6 oncoprotein in those cells, and because you have E6 oncoprotein in those cells, you're going to get ubiquitination of P53, and because you have ubiquitination of P53, you're going to have breakdown of P53, and what's that going to mean? You don't have your guardian of the cell cycle. What does that mean? You get carcinoma. You get cervical carcinoma. All right. And the HPV E7 oncoprotein, similarly, will bind retinoblastoma and pull it off of E2F. So now E2F, remember, what was retinoblastoma? The gatekeeper of the cell cycle. So think about what HPV has done. Not only has it completely annihilated the guardian of the genome through ubiquitination, it's almost as if it's seduced retinoblastoma. It like assassinated P53 and seduced the retinoblastoma protein and pulled it away from E2F, because now E2F can go in and drive the cell cycle. So not only are your cells constantly dividing, there's no way to prevent that or to fix the damage that might be going on in these aberrant cells. And that allows you to carry forward harmful mutations from one generation of neoplastic cells into another. And that's what gives rise to HPV. That's what gives rise to the carcinoma. That's why the pap smear is so important, because we can take a scraping, we can sample the scraping for HPV, and then if HPV is present, we can look at the cervix take a sample and assess what do we need to do to prevent the development of carcinoma in this patient. All right. And neurofibromatosis is just another tumor suppressor gene. If you remember from the lecture on RAS, and I would recommend you to watch it if you haven't, because I'm not going to review it here. RAS drives the cell cycle forward. So this is a pro-cell cycle protein. In fact, mutations in RAS that switch it on are called oncoprotein mutations, right? Because they're driving growth, because RAS is a growth protein. But this tumor suppressor NF1 is one of the negative regulators of RAS. So it's sort of one of the brakes on RAS to prevent too much growth. In neurofibromatosis, what happens is there's mutations of NF1 and you get the development of neurofibromas and some other neurologic tumors like gliomas. But I'm not going to spend too much time there. The last mutation I kind of want to cover is the Wilms tumor mutation. And WT1 is very important in allowing the normal differentiation and apoptosis of kidney cells. Right? What does that mean? Differentiation is the process by which cells acquire their cardinal characteristics. So if you nix their ability to do that because you have a mutation in WT1, the Wilms tumor mutation, you don't differentiate. So those cells kind of stay amorphous and they grow a lot. Why? Because they don't do apoptosis, because WT1 is important for differentiation and apoptosis of kidney cells. So you get this growth, this growth, this growth. And what I like to call it is you have some kidney with your tumor. You don't have a tumor on your kidney. You have some kidney on your tumor, because classically what this will look like, especially on examinations, is a giant tumor. So this is all tumor, and then an itty bitty kidney attached to it. All right. So those are the main tumor suppressors. Hopefully this was informative to you. There aren't a lot of resources that sort of combine and bring together all these concepts, so I wanted to provide that for you. All right. Hope you have a good one.